So I'm going to talk about, or I was tasked to talk about durvalumab, EV and pembrolizumab, and other neoadjuvant approaches to bladder cancer. And some of this has been presented in other talks. And so sort of try to summarize things quickly. And these are my disclosures. And so we've already heard, I think it was in the first session, a presentation based on the Niagara study. And so this is the recently published in the NEJM study, looking at perioperative durvalumab in combination with gemcitabine and cisplatin neoadjuvant chemotherapy as compared to gemcitabine and cisplatin neoadjuvant chemotherapy. And here the dual primary endpoints were event-free survival and pathologic complete response rate. And again, as stated earlier, it also included a small group of patients who had a compromised creatinine clearance that were allowed to receive split-dose cisplatin. And so these are the data from Niagara. Here, the study was a positive study. It demonstrated an improvement in event-free survival with a hazard ratio of 0.68. And it also showed an improvement in overall survival for the perioperative approach with a hazard ratio of 0.75. So what else is going on with durvalumab? Here is the VOLGA study, and this is going to be discussed in more detail later, but this is a study looking at the combination of enfortumab vedotin, looking at the combination of immune checkpoint blockade with durvalumab and tremelimumab in cisplatin-ineligible muscle-invasive bladder cancer. And you can see the arms here, and this study has a perioperative approach that is with an adjuvant component as well. And some preliminary data from this study, including safety data, as well as some cfDNA data, has already been presented. There has been data that is presented as related to the use of enfortumab vedotin in the neoadjuvant setting. And so this is from the multi-arm EV-103 study. There were two cohorts, one that looked at neoadjuvant EV. This is cohort H. And there was another that I'll follow up with looking at a perioperative EV strategy. And here the pathologic complete response rate was 36%. So this is, I think certainly promising, and the median EFS had not been reached, and at 12 months was 76.4%. And this is, I think we'd all agree, not unlike pathologic complete response rates that we've seen sort of across the board. And that's why it's so important to follow the time to event endpoints in these studies. This is cohort L that was presented by Kala Sridhar at ESMO in 2023, and similarly a pathologic response rate of 34% here, and we don't have the time to event endpoints. So there are these studies, which are going to be, I think, as we would all agree, very important in understanding how the treatment landscape is going to change. I think Niagara is exciting in that it represents a standard of care approach to the management of patients with muscle-invasive disease. It may have a short shelf life based on these upcoming studies that will eventually report out. And this is EV-304, which is looking at cisplatin-eligible patients, again, using a perioperative approach with EVP as compared to cisplatin-based chemotherapy. And then the EV-303 study, which is looking in cisplatin-ineligible patients. And you can see here an immune checkpoint inhibitor arm, and then the combination of enfortumab with pembrolizumab. So is it possible to select patients with muscle-invasive disease who do not need definitive management of the bladder, that is cystectomy or trimodality therapy? And there have been a number of efforts, and several are ongoing to try to address this question. I just pulled one study. This is a study by Dr. Galsky, the HCRNGU 16257. This has been published. And here, using a very rigorous assessment for a clinical complete response, gemcitabine, cisplatin, and nivolumab was delivered in the neoadjuvant setting. And in those patients who achieved a clinical complete response, they were to go on to no cystectomy, and there was an adjuvant nivolumab component. And here, 43% of the patients achieved a clinical complete response. And you can see the outcomes of the patients achieving a clinical CR. And bottom line at the end of the day, in this small proof of principle type study, to be bladder intact, alive, and with no evidence of metastatic disease or 23 of those 33 patients, 70%. So I think, folks are excited certainly about the ability, patients in particular, to be able to not have to undergo a cystectomy and maintain their bladder. Here are some additional studies. So this is the RETAIN-2 study. This is done by Dr. Geinesman from the Fox Chase Group and Betsy Plemack and others. There was a study that came before this, the RETAIN-1 study. The RETAIN-2 study is looking at accelerated MVAC and nivolumab. And this is looking in patients with recognized DNA damage repair gene alterations that have the potential to confer exquisite sensitivity to cisplatin-based chemotherapy. And there's another study that's ongoing that is looking at chemotherapy with cisplatin in the neoadjuvant setting with this type of approach by Gopra Iyer within the Alliance. And then here is another study by Dr. Galsky, HCRNG 204444, looking at neoadjuvant pembrolizumab. And so I'll end a little bit early, but I think there's a lot of promise in looking at these type of strategies as bladder preservation type approaches. And I think, ultimately with the integration of immunotherapy, enfortumab vedotin, the use of circulating tumor DNA, and the recognition of the exquisite sensitivity of specific DNA damage repair gene alterations to cisplatin-based chemotherapy, I think the landscape is going to change. And hopefully we can really begin to understand and select patients for individual approaches over time. Thank you.